welcome today. I am so excited. I have a guest with me, Dr. Isabel Amigues. She is a rheumatologist and a good friend, and I'm so excited to talk with her about the role of arthritis, inflammatory arthritis, how diet plays a role, how some of these medications play a role. We were talking because about a month ago now, a really interesting paper came out talking about some of these new medications, the GLP-1 receptor agonists, and how they can play a role. And so we're going to talk about that and all of the good rheumatological stuff today. So, Dr. Amik, thank you so much for being here today.
Yes, and thank you so much for having me. Such a pleasure.
Yes, I'm so excited. Tell us a little bit about yourself.
Yeah, absolutely. So I'm a rheumatologist. So I'm French, cannot hide it. I have the accent. So I did rheumatology actually. I did everything in France, in Paris and in Lyon, in France. And for love, I moved to the US, but it wasn't that easy. I had to do all of the training again. The good thing is that it's pretty much free in France. So it was okay. I did the residency and fellowship again in New York City. I finished with fellowship at Columbia University. And I love rheumatology so much that it was really just a pleasure. In fact, I even extended it a little bit because I wanted to do more research. And then I moved to Denver, Colorado, that I love. And I was faculty practice in National Jewish, which is a faculty and researcher center. Did a lot of lung associated with rheumatologic disorder stuff. And then at 40, so almost 5 years ago now, I got diagnosed with stage 4 breast cancer. And I've done very well, continue to do so. And I really can thank the medicine, the Western medicine for it. But I also discovered a whole new way to approach conditions that included Eastern medicine, such as Qigong, energy healing, meditation, visualization, and things like that. And it was so powerful to me. So at first I thought, oh, this is placebo, right? It doesn't, like, even if it's
Mhm.
placebo, it doesn't matter. I want the placebo on my side. So I will take the 30%, because usually placebo is 30%. But then I started looking into it and saw actually a lot of good studies on all of those. And so I started to integrate it into my practice, and then realized that the type of practice I had with the faculty practice I was in didn't allow me to fully be this new rheumatologist that I had become thanks to this health crisis. And so I opened the first direct care slash concierge rheumatology practice in Denver, Colorado, a little over a year ago. And gosh, I love it.
Mhm.
It's just like, I think it's the most incredibly satisfying practice I've ever had. And it's funny because I thought maybe like I would miss doing research and things like that, but actually I want to, and I think there will be a time in my life where I will do research again. But for now, I'm just like enjoying taking care of patients, loving them, just making sure that they're doing well, and offering the best of me to my patients. So that's what I do, and I'm very happy. And I think it's cool to have this background of both a researcher as well as a clinician, and now really putting it all like to the core of what clinical care is. So yeah, that's me.
Yeah, I love that. And being able, your story is so amazing. Everything from your training into your cancer and being able to be in a place where both, you had double the training, right? Just simply because you did double the length of time, really, of any other physician out there, which is really pretty impressive. And your commitment to the field to do it again, right? We know a lot of physicians, my listeners may not know, but it's really common in medicine that people who've been practicing in another country, when they come to America, they think, oh gosh, maybe I'll be a fill in the blank, and they change their specialty. So I love that, rheumatology was so special to you that you continued to do that again. And we know that Eastern medicine, it's been around for millennia, right? And so we know that there are so many benefits of it. So the fact that you've been able to use that in your personal journey and sharing that with your patients, I absolutely love that. So thank you for sharing with us. I would love to hear from you. I have patients all the time who are dealing with arthritis. Sometimes it is osteoarthritis, sometimes it is inflammatory arthritis. And I feel like there's not always good messaging about what is the difference between those things, both in terms of diagnosis and even treatment. So I'd love to hear from you about what those two different things are.
Yeah, thank you so much for this question because it's really something that I try to put out. So I have my own like rheumatology YouTube channel, and that's like something I feel like I keep repeating over and over again because they like inflammatory arthritis carries so much more issues than osteoarthritis. So osteoarthritis is what we call mechanical joint pain. Mechanical in the sense of it's the mechanics of the joint that's an issue. And that's primarily an issue because as time goes, we are thinking that everything is inflammatory related. But for now, osteoarthritis has a genetic component and basically an overuse component. And so if you're repeating use, we are seeing, for example, a lot of the thumb are osteoarthritis because people are using their phone all of the time.
Hmm.
If you're a worker, in the street, you might have developed, like if you're using some of those tools that are vibrating on the street, you might develop some type of osteoarthritis in places that usually we don't see, and so on. And then
Hmm.
there's also this genetic component. And that type of pain is very different than the inflammatory arthritis. But before we go into this, the inflammatory arthritis is an arthritis that's associated and that causes and is due to inflammation. Mostly it causes inflammation. Um, and the problem with inflammation is that it can destroy your joint, so not great,
Hmm.
because then you can lose function. But it's actually more than that. Usually there is inflammation in your whole body. You may not necessarily see it, but you have it. And you may have more cardiovascular disease, heart failure, hypertension. You may have like lung disease. You may have skin conditions and fatigue, etc. And for me, one of the study that I was involved actually as a first author was so cool because it was at Columbia University, and we were looking at the heart of patients with rheumatoid arthritis who had no cardiovascular disease. And what we saw is the patients who had the higher activity of their disease, so their disease was more severe, we found that they also had more inflammation in the heart. There is no reason to have
Wow.
inflammation in the heart. But then, even better, we saw that it decreased, that inflammation in the heart decreased as we treated the rheumatoid arthritis. And so I think that that's very, very cool. And so
Yeah.
that really shows a difference between inflammatory arthritis and the mechanical arthritis. Now, in terms of how we distinguish it, and I think that that's very important for the people who are listening, there's
Hmm.
3 or 4 main questions that are really important and that can really help you like reassure yourself saying, okay, this is not inflammatory, or tell you like have a call to action of please go and see a rheumatologist.
Hmm.
One is that inflammatory arthritis is worse in the morning. That's number one. So is it worse in the morning or is it more like at the end of the day? If it's in the morning, if you wake up with pain, that's a problem, right? Like then do you have morning stiffness? So do you feel stiff, like as if you had to like wait until all the oil and engine in your joint are working? And that
Hmm.
is that would take that if it takes more than half an hour, we say that that's morning stiffness, that's consequential. So that is associated with inflammatory arthritis. And then do you have any swelling of the joint? Not the bony swelling, but like where, if you touch it, it's like a cushy feeling. That's inflammatory. And then does it get better with exercise? That's inflammatory. So I think
Hmm.
the free question that the patients can ask is, that you all auditors can ask, is your pain worse in the morning? Is it associated with more than 30 minutes of morning stiffness? And third, is it better when you exercise? If you respond one to any of those questions, I would recommend you see a rheumatologist because you may have an inflammatory arthritis. So I think
Hmm.
hopefully this helps. Each of those have like a full hour's lecture, but yeah.
Yeah.
Mm.
Yeah, I appreciate that because a lot of times we you hear people talking about arthritis, but it's not always clear what is meant. And it's very common when patients come into my clinic that they're dealing with osteoarthritis, commonly of the lower legs, of the knees is very common, of the hips, and it's common because we're bearing our weight on those. And we know, of course, that losing weight can make a really major difference in the improvement of those symptoms. But what we also know is that losing weight can improve the and symptoms of inflammatory arthritis. So I'd love to hear a little bit for you, like what does it mean to have inflammation? What is the role of obesity or excess adipose tissue, that excess fat tissue? How does that contribute to the inflammation in our body and then specifically in inflammatory arthritis?
Yeah, what a good question. What a good question, and one that has been looked at and continues to be looked at a scientific level with research and you know, metabolic syndrome or like overweight is affecting 1/3. No, wait, is it 1/3 of the population or even more?
Two
Um,
thirds, yeah.
2/3, right? Like it's
Hmm.
crazy. Like what I was saying, I
Hmm.
was like, no, it's more, but 2/3 sounds so much, and it's so
Well, it's
much.
about one third overweight and one third obesity. And so when we combine it, right, it's
Yeah.
significant. Like almost 70% or a little more than 70% of our population has overweight or obesity.
Yeah. Yeah. So there's a lot of conditions that are associated with it. And basically, so we know that adipose tissue is pro-inflammatory. That's, we know that in cardiovascular disease. We actually know this also in cancer patients. So for example, breast cancer, one of the things that I don't want to happen to me is a recurrence. So I look very much at what can I do to prevent that. And it turns out that there's a study that shows that overweight, so not even just obesity, but overweight is associated with more recurrence. So you're like, okay, and it's because we think now that cancer is a pro-inflammatory state. So now coming to the rheumatology perspective is we were not sure. We had some ideas that, for example, a lot of psoriatic arthritis patients, so it's a certain type of inflammatory arthritis, they tend to be overweight and obese. And we all had seen that, with improvement of their weight, they would be better. But there was no study per se. And then we started doing studies and we started seeing that there is a direct correlation between fat tissue or adipose tissue and number one, developing psoriatic arthritis or rheumatoid arthritis or inflammatory arthritis in general. And number two, with flares. So the
Mm.
activity, so how severe those inflammatory arthritis are, is related to how much fat you have in your body. And so very often what I would tell my patient is that it's not about how much you weigh, it's how much muscle tissue you have versus how
Mhm.
much fat tissue you have. And so if everything is muscle, we're good. Even if you weigh very little, but all you have is just adipose tissue, that's still a problem. And so there's such a correlation, like, you can actually look at the tissue, the fat tissue, and see that it's inflammatory. And it's really, really cool. Like the studies that are looked at right now are very, very interesting when it comes to inflammation and adipose tissue. Uh, I don't know if I answered your question. I was going to go somewhere else
Mhm.
after that, but yeah, that's the first piece.
Yes.
Adipose tissue or fat tissue is pro-inflammatory and causes rheumatoid arthritis, causes psoriatic arthritis. Those we know probably causes other inflammatory arthritis, to be honest. And it's associated with more severe disease, in both cases, like rheumatoid arthritis and psoriatic arthritis.
And so what do we do about that? Besides the obvious of lose
Yeah.
weight, how can we best support our patients in doing that?
So up until very recently, personally, my goal is always remission, especially in rheumatoid arthritis and in psoriatic arthritis. And we have a whole set of what we need to do because it's called the treat to target. So you start with maybe a DMARD and then a medication, oral medication, and then you go to a biologic, which is you go very directed against the inflammation. And really, honestly, in a lot of patients, it works superbly. And we get to full remission like that. And that's great. And some patients, I had this hint right there where um, I remember when I think it was the GLP-1 agonist, and I had a patient that had diabetes and that had, no, she was obese and she had psoriatic arthritis. And I remember thinking, I've tried so many treatments for you. and you haven't achieved remission. You're much better, but you haven't achieved remission. And I remember telling her, and it was at the beginning of all of those drugs. And I was like, I
Mhm.
think you would benefit from trying. And I think it was Trulicity maybe at the time.
Mhm.
And I was like, I think you should try Trulicity and see how that works for you. So she had diabetes, so got approved right away, started it. So there's a time where it wasn't so known, so not everyone knew about it. So she
Mhm.
started it, she had it, and she loses 30 pounds. But in the process, and in the process, not only does she lose 30 pounds, but she also gets perfect remission of her psoriatic arthritis. We
Wow.
had not changed anything else. That is the only thing that did. And so the reason I share this is that when you have inflammatory arthritis, you have pain. So it's very hard to say, oh, just exercise, you know.
Mhm.
We all know, like, it's not easy to lose weight, especially if you have insulin resistance, like after menopause, or, if you have diabetes, it's not easy to lose weight. And I'm so upset every time someone is like, oh, just lose weight. And they're like, okay, yeah, sure. Tell me how,
Right. Yeah,
you know,
like, I haven't
you
been
cannot.
trying that. Yeah.
Yeah. It's like it's kind of ridiculous. And it's always the woman that get that. I feel like in men, we don't usually say that. Like, we don't hear that as often. Like, but
Mhm.
woman is like, yeah, you should just lose weight. And I'm like, wait, what? Like, tell me
100%.
how. Tell me how. Really, that's important. Uh, so then comes, and I think that that's what you were referring to, this article in Nature, which I think is just a review, like a small review article to show that all of those drugs, and so this is where I get so excited. Because, right, so you could say, okay, well, we're decreasing the adipose tissue, we're decreasing the weight. So because you're decreasing the weight, you're decreasing the adipose tissue when you use GLP-1 agonist and semaglutide and so on, right? And that's great. And that by itself is going to decrease the inflammation that's associated with my patients with inflammatory arthritis. Now, do they have their own anti-inflammatory mechanism is a question.
Mhm.
And that is very cool, right? Like, remember my patient, she loses 30 pounds and she also gets into remission. So that's just one example. I've got some other ones since. But then I think it's really cool to say, well, what if the first step in treatment of a patient that's obese would be to lose weight and to help them with that, right? So I think we say that first you lose weight, then you exercise. I think it keeps changing, but it's first you
Mhm.
lose weight, then you can keep exercising. You can start exercising because having less weight allows you to have more energy and to work out. But I think it's really just this approach of, can I help your inflammatory arthritis from both sides? And really, like, it's the third side, the side of I'm helping the inflammation directly with the drugs that I know in rheumatology. The second side is helping the inflammation by decreasing your weight. I'm also helping maybe the inflammation by those new drugs as well. And then the
Mhm.
third side is this empowerment of the patient of lifestyle changes, and then more exercise and a better diet. And we if you want, we can talk about anti-inflammatory diet, but really, like,
Mhm.
this holistic approach of, it's not just one thing, because we are so complex. It's really just attacking, and it's not attacking, but um,
That's really
managing
comprehensive,
different.
yeah. Mhm.
Yeah.
Yeah, and I think that's because that's exactly it, right? When we think about our bodies are so complex. It's never going to be, let's just do this one thing and it changes everything. These medications, whether we're talking about for the treatment of obesity or for the treatment or support of inflammatory arthritis, they are just part of the picture. And when we can think about the other medications for arthritis, thinking about the dietary changes, the exercise changes, what is the comprehensive lifestyle that involves? And yeah, I would love to hear that from you because we often hear inflammatory or, I want to follow an anti-inflammatory diet. And what does that really mean?
Well, yeah, that's such another excellent question. I will say that I didn't understand it either. And I thought anti-inflammatory diet and Mediterranean diet and whole food plant-based diet was all three different diets. And then you start looking into it and you're like, no, 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 no. They're actually almost the same.
Mhm.
So a whole food plant diet is just the same than a Mediterranean diet, just without the fish because or the meat because you're trying to not have any animal protein. An
Mhm.
anti-inflammatory diet and a Mediterranean diet, if you look at it, it's literally the same. So
Mhm.
then I can, speak about the inflammatory diet. The inflammatory diet is basically the SAD diet, standard American diet. It's really sad because it's basically all
Mhm.
what my kids want: burger, bread, processed food, sugar, and the truth is that we are made to like this. It's not our fault. We like sugar when we were made as like the first human. If there was sugar, you wanted to pile that up because you didn't necessarily have access to the sugar in a long, you didn't have access to the blueberries or the raspberry or strawberry the whole year, so you wanted to pile that up so that you would have access to reserve during a time where there was not as much food. The
Mhm.
problem is that now we have enough food, right? And so then they create inflammation because they are piling up, and they do create more fat, and then ultimately that's inflammatory. And then on top of that, there are some nutrition choices that are not nutritive and are pro-inflammatory, and that is usually processed food, sugary food, and red meat,
Mhm.
mostly, right? And it is it is proven that is pro-inflammatory. Like it is proven that people who eat this have more chance of having rheumatoid arthritis, and it's proven that it can cause flare. And in fact, like I have so many times my friends with my patients, sorry, would tell me that they would develop flare if they eat sugary stuff. And
Mhm.
so then an anti-inflammatory diet or the Mediterranean diet is pretty much a diet that's choosing to stay away from this. And I will give you a really cool example. So I'm French. My
Mhm.
family comes from the south of France, so Mediterranean. They are coming from Corsica. And when I was a kid, I would hang out at the cemetery. It's not creepy. It's not sad. Imagine the sun, the view on the sea, and you're by the mountain. It's actually beautiful.
Mhm.
My grandma would go and take care of the tomb, and she would meet other people because it's a very surprisingly very social place. Or at least
Mhm.
it was. I don't know that it's still a
Yeah.
social place now, but then you have me as a kid and my brother and my sister, and we're small, and we start like just playing in the cemetery, and again, beautiful sun, like blue sky,
Mhm.
the sea not far, so it's kind of fun. And uh the cool thing was for me I was learning how to do subtraction, and a very cool thing was to start like realizing that a lot of people had lived to be 98, hundreds, 90, like
Mhm.
six. And I mean, we're talking when I was young, right? Like less than 10 years old.
Mhm.
So that's 35 years ago.
Yeah.
And when um, like those people had died much before.
Mhm.
And it turns out, like we know that they eat a very specific diet because what do they have? They have access to a little bit of meat, and that would be the type of meat that you would eat only during the big holidays, so Easter or Christmas, something like that. And like I can just think of what my grandma would make to know what an anti-inflammatory diet or Mediterranean diet is. So they would eat a little bit of fish, very little. They would eat very little amount of meat. They would eat a little bit of fish, but not that much. And really, what they were eating was salads, like products of the garden, right? And salads
Mhm.
and chickpeas, and like tomatoes that had so much taste, and olive oil, because that's a like Mediterranean area where you can do olive oil. And
Mhm.
there was a little bit of bread, even though here, I don't know, like the bread in this country is definitely processed differently than in France.
Mhm.
But you would have one piece of bread, right? Like it's not like the whole bread. And so then
Mhm.
you're thinking, okay, well, so a Mediterranean diet is a diet where you enjoy your food. It has a lot of taste, And you have moderation in meat and moderation even in fish. And really, it's more whole food, plant-based. That is an
Mhm.
anti-inflammatory diet, and that works. If you do it, you feel better. If you do it, you have less joint pain, you have more energy, you have, and it's proven in so many countries and in so many places. Um, and that's what we should all strive for. So yeah, that's the
Yeah.
anti-inflammatory. I
I
hope
love
it's,
you
I
sharing
don't
that.
know, I went on the tangent of the cemeteries and
No, I love it because I think, one of the things I say to my patients sometimes is, would your grandmother recognize that food? And so if your grandmother has no idea what you're eating, it is not real food, right? If it is not made of real ingredients combined together, my grandmother would recognize a chocolate chip cookie. She would not recognize, even a protein bar, for example, right? Like what is this food that we or food-like item that we are putting into our bodies?
yeah, and I always go back. I'm someone who really likes like I like fairness. I don't like when things are unfair. And one of the thing that that really like I cringe is the fact once you know that the reason uh people are tending to all of those really bad food, right? Because we all know it's bad. And
Mhm.
I would say like the other day I had not eaten, and where did I gravitate towards? Like there was a smoothie, and then I was like, wow, this smoothie is really good. And then like you realize that there's like 23-gram added sugar. And so
Right.
then it's like realizing that if we like something more than the spinach, it's probably because there's added sugar because that's their way of selling.
Mhm.
And so then we realize that and we're like, okay, do I want to be manipulated by the system or do I want to do my own choice? Um,
Mhm.
and it's not necessarily, I think I personally try to give myself some grace, and I definitely give my patient grace. It's funny how we are always harder on ourselves when it comes
Mhm.
to food because it's not easy. Like everything is made so that we eat the processed food because it costs less money to make and
Mhm.
it's highly addictive. And so you're going to eat more of it and
Mhm.
less
I
satisfying.
always say that is someone's full-time job, right? There are food engineers who their entire job is to work on what is the texture and the flavor and the mouthfeel. And there are people who get paid lots of money by every single corporation in order to make that Oreo. An Oreo is perfectly designed to be crunchy and then creamy and then crunchy and got the tiniest bit of salt to balance the sweet. That is someone's full-time job. That is many people's full-time job,
Mhm.
right? Is to create and craft the Oreo. And so when you think about that for all of these highly processed foods, it's like, of course, like they are designed to be really addictive. And what I think is really fun though is that some of these real foods can be really, really, really delicious also. And I think that's part of it too, is learning how to prepare them and how they can be enjoyable. Because I used to hate broccoli, for example. I thought it was bleh. And it took a really serious dedication of, okay, it turns out I don't like broccoli when it's over steamed in the microwave. But when I roast it or when I saute it or when I do these different things, it's actually much more enjoyable.
Yeah, that's exactly it. That's exactly
Yeah.
it. Discovering the pleasure in eating food at a different level. Um, and it takes a food education. It's not easy, but it's so powerful because then it empowers everyone to make
Mhm.
choices.
Yeah.
I love bread, right? And so I started like doing my own bread with flour that comes from France. And
Mhm.
yeah, I felt less side effects from it, like because otherwise I feel pretty bloated if I eat bread from here. And that was
Mhm.
kind of cool. I was like, oh, I'm empowered to make my own bread. It's cool.
Yeah, I love that. Well, and thinking about, each of our journeys is going to be different. And there's these general principles that we can apply to anyone. And looking at, even if you're desiring, like, oh my gosh, I wish I could eat these healthy foods and I just It's so challenging. That's where it's been really neat to see some of these medications, the role that they play in the food chatter, in supporting the healthy decisions that we're already making. And you probably know semaglutide just got FDA approved last week for cardiovascular risk reduction. So, not for diabetes, not for weight. And so, we're starting to see it. And it's fun to think, are we going to see it for inflammatory arthritis and for these other conditions? Because our weight is really just the result of so many things in our life. And so, thank you for coming on to share that. Let me ask you, as we wrap up, is there anything that you'd like to share with our listeners?
Yeah, I mean, I think we touched about so many things when it comes to food and inflammatory arthritis. But I do have a podcast, and I think I do have a podcast on AbridgeMD where I really would love to have you on. And then I also have a rheumatology YouTube videos where it's called Rheumatology 101 by Dr. Isabelle Amigues, but it really Rheumatology 101, and you should be able to see it. Um, because I'm really like it's really important to educate patients and to educate ourselves really
Mhm.
in this in this landscape that's ever changing, and there's so much, and there's data that and there's like people who are scientific, and there's other people who are not scientific, and what's real, what's not, and is there any data, and so on. So love educating, and so always happy. And then of course, if anyone has a rheumatologic condition, I'm happy to take care of them if they are interested. My On the social media and everything, my practice is called Unabridged MD, for the non-edited version of the physician and the patient. So yeah,
I love that. And we will share all of your links in the podcast notes so any of my listeners can check you out there. Thank you, Dr. Meek, so much for joining us today. We really appreciate it.
thank you.